Good afternoon, everyone, and welcome to this webinar, Reflective Conversations, Reaching In, Reaching Out, How to Access Support Services at the Royal College of Psychiatrists. My name is Simon Hyland. I'm a consultant psychiatrist in medical psychotherapy in Birmingham and chair of the college working group on reflective practice. And it's my pleasure to be chairing this webinar today. As you will have seen from the diagram on the slide at the start of this session, the college has a range of types of staff support, and we're going to be hearing about some of those today from leading members of the college involved in that work. It's no coincidence that two of our speakers today are medical psychotherapists. Medical psychotherapy is a psychiatric specialty whose work includes substantial roles in staff support, both for junior doctors and for permanent staff, including here at the Royal College. This is often in ways which offer a combination of clinical and wellbeing functions, such as balance groups and team reflective practice groups. So thank you to everyone for joining us today to hear about some of what our college offers to its members. Just some housekeeping from me. We've got 385 people signed up to attend today, so I'm sure there'll be plenty of questions raised in your minds by what you hear from our speakers. During the webinar, please use the Q&A button at the bottom of your screen to submit any questions, and we'll be having a formal Q&A with the panel to close the webinar. You can also message the panelists and the organisers privately using the chat box during the webinar. Please tweet throughout the event using hashtag RCPsych Live. You can also tag at RCPsych and at RCPsych PSS. All of those details will be put up in the chat for you by the college team. The webinar is being recorded, and the recording will be available to watch on the college website from next week onwards. Your certificates of attendance will be sent out within the next week. In terms of any further information that you might want, if anyone has come looking for support services or feels affected by issues raised in this webinar, please look in the chat for relevant contact details being posted by the college team live. Details will also be summarised at the end of the webinar for anyone who wants them. And finally, before I introduce our first two speakers, we're going to do a very brief poll asking you 4 questions of relevance to today's topic. Please take a moment to answer those 4 questions now, and we will be looking at those results later when we get to our Q&A session towards the end of the webinar. The poll on your screens will only be open for a maximum of 60 seconds, so please don't agonize over your answers. Okay, so the results of that poll will be available at the start of our Q&A session, and we'll get the views of our panelists about your answers there. So without further ado, it's now my great pleasure to introduce our first two speakers today. Dr. Ros Ramsey, consultant psychiatrist at South London and Maudsley NHS Foundation Trust, where Ros is also the Deputy Medical Director for Medical Workforce. She's the Specialist Advisor for the Psychiatrist Support Service at the college, a member of the Individual Support Team at the Professional Support Unit at HEE London, and she volunteers as a peer support doctor for the BMA. Joining her as speaker is Dr. Sukhmeet Singh. Dr. Singh is an ST5 dual trainee in intellectual disabilities and child and adolescent psychiatry in the west of Scotland, and also a peer support psychiatrist and member of the Psychiatrist Support Service at the college. So over to you both.
Thank you very much for that introduction, Simon. So we're going to take you through just a brief description of the service, and this is where we are. So the Psychiatrist Support Service. Let's go on to the next slide. We'll have a little bit of what the service is, the background to its being set up. We'll talk to you about how it works, and then Sukmeet is going to share some data from the service. Let's look at the next slide. Okay, so this is a definition in a nutshell of what the Psychiatrist Support Service is. It provides free, rapid, high-quality peer support by phone to psychiatrists of all grades who may be experiencing personal or work-related difficulties. The service is totally confidential and delivered by trained peer support psychiatrists, or PSPs. Our PSPs are from diverse backgrounds and have received training in many different areas to improve their understanding and ability to support all those who call the PSS. Okay, let's look at the next slide. And the background of the service, as you can see, we have a long history now. There was a trainee in Northeast London who experienced significant mental illness with a further episode after the birth of her child. And in the event, she took her own life and the life of her young child. And this tragedy led to a lot of reflection on how such a terrible thing could be in any way prevented, and what we might need to offer to our members. So a scoping group was chaired by Professor John Gunn, and the scoping group listened to accounts from doctors of their different experiences. There are a number of themes around isolation, loneliness, lack of support network, and also not knowing how to access help. The following year, 2007, the Psychiatrist Support Service, the PSS, was started. So next slide. So the different roles in the Psychiatrist Support Service. We have the peer support psychiatrists, the PSPs, who take calls from college members at a mutually convenient time. We have a manager who sits within the college and who oversees the calls and manages the service on a day-to-day basis, and has that she's the first point of contact with the service, if you like. And then there's my role as peer Psychiatrist Support Service Specialist Advisor, and that's a leadership role working alongside the PSS manager. If you look at the next slide. So a little bit more about the peer support psychiatrists. So this group includes doctors in training, like Sukmeet, who is here, and we have an SAS doctor as well. And as a group, the peer support psychiatrists are well experienced in providing support to colleagues. They need to have good professional standing, up-to-date CPD. Appointment is through advert and interview. The peer support psychiatrists, we meet 3 times a year for support for ourselves, peer supervision, and also for our own professional development as peer support psychiatrists. There's also an outreach role with attendance at different college faculty sections and division execs and conferences. Next slide. So essentially, when the Psychiatrist Support Service manager has a call, the manager listens and offers support. That may be sufficient in itself, or as needed, the manager will signpost the caller and refer them to a peer support psychiatrist. The peer support psychiatrist has the call and then will feed back to the Psychiatrist Support Service manager. I've mentioned the peer supervision in the last slide, it's a really important part of supporting the work of the peer support psychiatrists. It's the supervision group is facilitated by a medical psychotherapist, and to really encourage us to reflect on the calls and our learning through that. Next slide. There's a whole slide here, as you can see, about confidentiality, because it's just such an important topic. And this slide outlines the steps we've taken to ensure confidentiality, because fear of not having confidentiality can be very off-putting to a potential caller. So we've really tried to work hard to be confident that the service is confidential. Okay, next slide. And as well as taking calls, the peer support psychiatrists have contributed to developing a whole series of different help sheets. And these cover topics which have come up on a regular basis through the calls. And you can see we've grouped them into different areas: training and transition, perhaps transition from trainee to consultant, for example, your health, managing your career, and then fourthly, difficulties in the workplace. With a number of different topics here: dealing with difficult colleagues, being excluded, coping with complaints, bullying and harassment, stalking, whistleblowing, reviews, investigations and inquiries, managing boundaries, and probity. And these help sheets are available on the college website. So I mentioned the signposting. If we go on to the next slide, thank you. So these are just some of the services that the peer support psychiatrists or the PSS manager may signpost a caller to. And you can see it's quite a range. So we have the BMA wellbeing support services, defence organisations. So if a caller is part of a defence organisation, have they had contact with that organisation? Dog health, which is a service provided by medical psychotherapists and takes a psychodynamic approach to offering therapy to medics. There's the Doctor Support Network, the GMC, NHS Practitioner Health. That's a service dedicated to providing health assessments for medics. It's very recently expanded a little bit to include other staff working in the health service. And then sometimes what's needed is something very practical, perhaps some financial assistance. So the Royal Medical Benevolent Fund provides just that. And then also the Sick Doctors Trust. Next slide. Over to Sigmeet, who's going to share some of the data with you to tell you a little bit more about our service.
Thank you. So firstly, considering the calls that we receive by the grade of the doctors speaking to us, the majority, as you can see here, are consultants, but trainees make up 35% of the calls that we received last year, which has been a consistent percentage even before the pandemic. So it's not as if this is something new. Of the trainees who phone us, the slight majority are core trainees compared to higher trainees, and we also receive calls from SAS doctors, and the unknown category here being doctors who don't quite fit into those brackets. On the next slide, we can see that the majority of our callers are women. On the next slide, this slide shows the primary issue that the caller tells us about. So these would be the first thing that they say to the PSS manager, either by telephone or email. And as we can see here, the most common issue appears to be work-related stress, followed by mental health, and then training, bullying, other health problems, and exams for trainees. But what we then find is, in listening to the caller as the PSS manager and as the peer support psychiatrist, that they there are an amalgam of issues, whether it's these issues or also other issues, such as those Ros talked about in our help sheets, like stalking can be an issue that comes up, as well as experiences of discrimination, difficulties being an international medical graduate and adjusting to the culture in the NHS. For trainees, obviously this slide shows issues to do with training, which might include difficulties with supervisors, as well as difficulties with ARCPs and the stress that that might cause, and problems with exams. For trainees in particular, it's worth considering as we do the age and stage of the trainee, in that for IMGs who are trainees, they might only have recently moved to the UK, so they're still adjusting to the culture within the NHS, and still dealing with some difficulties which consultants who are IMGs might have become accustomed to or adjusted to. On the next slides, this slide from last year shows that the majority of our callers didn't feel that COVID was part of the issue that they were phoning us about. On the next slide, this shows the data for our PSS webpage and help sheets. And as you can see here, last year, our website was visited a total of almost 5,000 times. We hope that this year it will be visited more times. The most common help sheets from 2020 to 2021 were the help sheets to do with stalking, bullying, harassment, and looking after yourself. And the exact numbers of the different help sheets does seem to vary year on year, but stalking and bullying, harassment and looking after yourself, the ones here are very common help sheets that are accessed. On the next slide, this slide is just some comments that we cherry picked, some positive comments that our callers wrote to us with during the feedback questionnaires that we send after the call. In general, we do tend to receive positive feedback, and as you can see here, I won't read the comments out, but callers telling us that they were able to get a bit of perspective on the problems that they have and to receive some non-judgmental feedback and to feel validated if they're in a complex situation. On the next slide, this is the final slide, which is just showing our contact details, which have also been posted in the chat. And with that, we'll hand over to the next speakers.
Thank you, Ros and Sukhmeet, so much for that overview, detailed overview, and also that data about the Psychiatrist Support Service. I, for one, certainly feel much better informed about it myself now. And we're now going to move on. And I would like to introduce our next speaker, Dr. Jan Bertel. Jan is a consultant medical psychotherapist and general adult psychiatrist who retired as Associate Medical Director in Worcestershire Health and Care Trust in early 2020. Due to the current crisis, she's returning to the NHS temporarily. Jan is Specialist Advisor for Coaching and Mentoring, working within the Psychiatry Support Service here at the Royal College. She has a long-standing interest in the health and welfare of doctors and in promoting this, including through provision of reflective practice forums. Welcome, Jan.
Thank you, Simon, and hello, everybody. Good to see you all, or not to actually see all of you, but nice to know there's such a content out there of people interested in hearing about support for their colleagues. I'm going to share my screen, hopefully. This will work. Okay, got the slides up there, I hope.
Yep, looks good, Jan, thank you.
Thank you, great. You get a slightly different view when you're presenting, I think. So, mentoring and coaching. Just go on to the next slide.
You may need to just click on the screen. Oh.
Yeah, got it, thanks, yeah. So we've heard from Ros and Sukhmeet about the Psychiatry Support Service, and the Coaching and Mentoring Network sits below that. We're linked in with them. And I'm Specialist Advisor in Coaching and Mentoring. We also have divisional leads in mentoring and leads from each of the devolved nations that are part of the network. And we've more recently introduced trainees to be represented on the network, along with SAS doctors. There's been quite traditionally a focus on new consultants getting mentoring, but we're really expanding that by thinking about mentoring right across the career, really expanding the access for SAS doctors and thinking about international medical graduates and fellows. And we're doing this really through training the trainers with an idea that we should be able to provide some mentoring access for all groups of doctors, including trainees and medical students, as we grow the resources to do so. Some information on the website, which I'll draw your attention to, but some important statements perhaps that mentoring and coaching plays a vital role in developing and supporting doctors. I think really importantly, thinking back to the organogram we saw at the beginning, nurturing medical leaders. If you go and talk to most medical leaders, they'll have had some coaching, some mentorship, but also thinking about helping a doctor achieve their full potential. So something about helping development, but also supporting people when they may be in difficulty or they've encountered some kind of barriers. And as we said, it can help you at any stage of your career. And actually thinking about all the changes that the NHS is constantly undertaking, really mentoring is very helpful, I think, in terms of building personal resilience. And I think it's also helpful to just think outside of the college, and in the GMC guidance, Good Medical Practice, which you'll all be familiar with, there is actually some content that relates to mentoring, saying you should be willing to take on a mentoring role for doctors and other healthcare professionals. And also, I think importantly, if you've agreed to act as a mentor, you must make sure you're competent to take on the role, which might include having some training. So what is mentoring and coaching, and are the two the same or are they different? I'll just briefly draw your attention to some of the headlines around this debate that is ongoing. Mentoring, some definitions include the Scope Me mentoring definition, guiding another individual in the development and re-examination of their own ideas, their learning and personal and professional development. It's quite a broad scope. Helping someone become better at helping themselves, that's Egan's view. And then if we think about coaching, again, there are lots of definitions, but here's one. Both coaching and mentoring are learning relationships which help people to take charge of their own development, to release their potential and to achieve results which they value. So I think that's helpful to think about. And what we're trying to do within the college is use a coaching approach in mentoring relationships. Okay, so coaching approach perhaps a little bit more challenging than traditional mentoring. This is just really a diagram showing you the principles of effective mentoring. The learning relationship is completely central, but around it is an ethical framework, which is really important as confidentiality, trust that can develop in this important reflective conversation. And then the key principles of coaching mentoring in more of a list form. The client is resourceful. So we start from a point of view of thinking this client is very resourceful. They may have got stuck. There may be barriers in their way. They may be very aspirational to go on to the next level of their career, but they are resourceful. And the coach's role is to spring loose the client's resourcefulness. I really like that statement. So like just tapping into it and helping them to find their way. Coaching addresses the whole person. The client sets the agenda. There's a sense of equality in a coaching arrangement. And coaching is also about making change, reflection then leading to change and action. And I think that's important. I won't say too much about this, but you can have a copy of the slides and have a look at them. Mentoring tends to be an ongoing relationship over a longer period of time, often with somebody with a similar professional background. Coaching short, often a person working perhaps as a professional coach, and is quite structured and scheduled. But the two do definitely have quite a bit of overlap too. So within the college, what we're interested in doing is using the network to try and get a shared understanding and approach to coaching and mentoring, because I think people have had quite different ideas about it over the years. So we have shared training resources, and we've had training for the leads in the college, supported previously by a programme. We also have some CPD groups for ongoing learning and reflection. And we think very carefully about the quality of this relationship and experience. And also, as Ros quite rightly pointed out, talking about the PSS, confidentiality is absolutely paramount. If doctors don't feel safe to talk, then they're likely to just hold back and not really put themselves in the frame fully. We sometimes signpost people to other services, and we think carefully about professional and ethical issues. We've tended to use the GROW approach to coaching. There are lots of different frameworks, but this is quite helpful because we've got sections of thinking about the goal, the reality of achieving the goals, what helps it, what hinders it, possible options, just widening the horizons, and then focusing in on ways forward. What will I do? And how will I go about this change that I want to undertake? So that's just to give you a little flavour of the approach we use. And then certainly through the last couple of years, we've been working on raising awareness of the importance of coaching and mentoring in medical management, for example, making sure that people have time for coaching and mentoring factored into their job plans with their mentors or mentees. We've been doing some video accounts. There's one on the college website of Adrian James, our president, meeting with Hilary Grant, a medical director, and talking about their experience of having coaching. The various other links. I draw your attention though to our work around really helping think about diversity in psychiatry, been linking up with the International Medical Graduate Programme and BAME doctors, with the Diaspora Groups Committee, and doing some work with the Association of Black Psychiatrists, where we've been helping them to become trained mentors so they can have culturally appropriate competencies to use coaching and mentoring with their colleagues. And that's been an ongoing conversation about how we could assist them in helping that. And similarly with SAS doctors, we've had training programs for them, including sessions in Northern Ireland. And trainees have really been taking the lead in developing some peer mentorship. So there's quite a lot of things going on, which is quite exciting times for us. We're also rather outside the college, doing a little bit of work around with other organisations, NHS professionals, to support gateway programs, and a few of us are involved with the Doctor Support Network, where there is a coaching program in place to help doctors in difficulty from different professional specialty backgrounds.
You have 2 minutes.
Thank you. The 7 ages of man, I think it's just helpful to think about transitions through our careers, because I think there are various times in our careers where things go smoothly and perhaps less smoothly, but we have certain characteristics perhaps happen at different times. And coaching can contribute at these transition points, at mid-career stasis, whistleblowing, and following various traumas. Perhaps one thing we don't do terribly well as doctors is to use support. So I think there's something here about how we might reach out to make connections with our colleagues and reach in knowing our own strengths. And again, reflection is about thinking about ourselves, thinking about our interactions with others, what they are seeing in us and how we can make connections with them. So this is really about how we can think about using resources to develop ourselves, including becoming a mentor. And I'd certainly encourage people to train in mentorship. It's really enjoyable, fun work, actually, a lot of the time. So how does it benefit doctors? I think that central part that we've talked about is that relationship of trust that facilitates a conversation that is confidential. The opportunity to reflect with another person while you bring your own agenda in. And also just thinking about both conscious awareness and unconscious factors. Why do I keep falling down the same pit, tripping up in the same sort of way? What's happening? Is that something about me that I can look at? But I think it certainly does help with leadership, with helping with agency, with helping people find their maximum contribution. And just an idea here about, it's been put together by Oxley Fleming and Stephen, and they've thought about the benefits in terms of personal professional overlap. So again, just really important to think about, this is a person here, it's not just a doctor, a psychiatrist. And I think the other part that comes out of that is that a lot of the skills in coaching and mentoring also have generalizable applications in appraisal, for instance, which I think if it goes well can be very developmental in focus. So just a slide here, how to find a mentor, perhaps approaching somebody personally for a recommendation, but we generally advise to have a bit of distance between the mentor and the mentee. Some mental health trusts have in-house mentoring schemes, so there may be a clinical medical director who can point you in the direction there. The deanery is helpful for trainees. Faculty of Medical Leadership and Management runs a mentoring scheme, and some of the college divisions, the West Midlands is particularly one amongst them, have their own mentoring schemes. But there's also central mentoring support at the college if you want some details of that. And then just final slide, thinking about the wider systems. There's something like a psychiatrist in the system, making connections, continuously learning, using support, developing personal resilience and clinical leadership to further their career. And as Sir David Attenborough says, it's that range of biodiversity we must care for, the whole thing rather than just 1 or 2 stars. We are a community of psychiatrists and the whole is greater than the sum of the parts. So there are some resources on the website, which I hope you'll find useful, including a model mentoring agreement, ethical guidance, and guidance on setting up a mentoring scheme. Thank you.
Thank you, Jan, for all of that information. And I can say from personal experience, as somebody who's been having mentoring since I first became a consultant, that it's been a hugely helpful learning experience in my development. And now it's time to introduce our final speaker today before our Q&A panel. So I'd like to introduce Dr. Rachel Gibbons. Rachel has been working in the NHS over the past 20 years in various psychiatric settings as a consultant psychiatrist and a consultant medical psychotherapist in settings including inpatient and intensive care wards, outpatients and psychotherapy services, liaison teams, forensic and prison services. She's recently been working as the Director of Therapies for the Priory Group. She's a psychoanalyst and group analyst and current chair of the Patient Safety Group and the Working Group on the Effect of Suicide and Homicide on Psychiatrists at the Royal College of Psychiatrists. Welcome, Rachel.
Thank you, Simon. So I'll just share my screen. So I've got 10 minutes and what I'm going to talk to you about is resources to help you following the death by suicide of a patient. Now, I'm really delighted that I'm here, because when I had 3 deaths by suicide of patients in my first 4 months as a psychiatry consultant, there was nothing, and that was in 2008. There was absolutely nothing. So I'm absolutely delighted that the Royal College has provided support for us to develop a working group. So we've got a working group on the effect of suicide and homicide on clinicians in general in the heart of the Royal College, and we're producing resources and all sorts of different developments to help you after this traumatic event. So this was a key meeting I had. So in 2008, I was utterly traumatized, devastated, and part of me annihilated by this experience. And my heart had really closed down. And I met the chaplain of Beachy Head, who said, I really believe, he'd been the chaplain there for 20 years. I really believe that to help a truly suicidal person, you have to approach them with an open heart. And this was a sort of transformational comment at this time, because my heart in a way couldn't have been less open. And so, you know, this is hopefully to help address that, because I think the closed heart and the difficulty with approaching people who are truly suicidal with an open heart is due to us being a traumatized workforce. And I think there is different reasons for that. And that's a sort of picture shouting out to COVID as well, post-COVID. But I think there's a sort of trauma underlying at the heart of the workforce. And this is by undigested experience of suicide and homicide. So in 2008, you couldn't talk about it. So there was lots and lots of people traumatized, and teams and whole organizations traumatized in this way, with absolutely no way of digesting this trauma. And if you can't digest trauma, it just lives in you and then sort of gets reenacted. And I don't doubt I had a post-traumatic stress disorder as a result of these early experiences. I probably still have it. And I know that I'm not alone in that. So this type of undigested trauma is increased and exacerbated by organizational processes and coronal processes. Whoops. And this means that working with an open heart with those who are in distress and suicidal is profoundly inhibited. So if we don't address this trauma at the heart of the workforce, other wellbeing initiatives will be able to achieve very little, be like putting a sticky plaster on. And what happens is, because we're so traumatized, our perception of our roles gets distorted, and we turn away from open-hearted amelioration of distress and therapeutic engagement towards the unachievable task of being totally preoccupied and focused on trying to predict and prevent individual suicides. We collude also with the delusional belief that someone can be to blame for someone else's death by suicide, which again is a vicious cycle and increases our stress and distress. So what is the Royal College of Psychiatrists doing to address this core problem? Well, it's being addressed in many different places now. It's very much pushing at an open door. The patient safety group, the working group of the effect of homicide and suicide on clinicians, that's suicide and homicide, the psychiatrist support service is discussed, and the wellbeing committee. We have a web page, and I'll show you this web page when I finish my presentation and show you how to navigate to it, where there's lots of resources. There's different resources on there, and I'll try and show you them. We've also been having conferences and workshops, and we had our first ever, the Royal College had its first ever conference last year, October the 22nd, on the effect of suicide on clinicians, and it was very well attended. And we've been writing, and we've written. It's going through the Royal College processes at the moment, guidance for all mental health organisations for the pastoral care of their staff following a patient death by suicide. And another major part of why I'm here is also to let you know about a relatively new initiative we've got started that is based on a more developed initiative that was located in a North London trust. It's now, we've got an online Royal College of Psychiatrists peer support suicide group, if you like. It's for psychiatrists of all grades in all the devolved nations. When you've had a suicide of a patient and you're feeling traumatized by it, it's a confidential peer support group that's run every 2 months now, that you can come and join and get some space with experienced clinicians, you know, people who've been through very similar things, have some space to digest and reflect on your experience. And this is what, having a group like this is what absolutely saved me over the years. So this is just speaking to some of the resources that you'll see on the website when I show you. We've got creative conversations about suicide, which are videos of psychiatrists and service users and carers talking about different aspects of suicide. And we're trying to have as open-hearted discussion about really challenging aspects of suicide. So you've got psychiatrists talking about the effect that a patient's suicide has had on them very openly. We've got how to talk to those bereaved by suicide, how to work with families. So what's the nature of suicidal ideation? So we're having a sort of debate, discourse around these different areas. So they're on the website as well. We've got a booklet there, which you all hopefully have got circulated to you for all psychiatrists and all clinicians following the suicide of a patient to help you. We've got research on the effects and publications and information about other conferences. And there's many presentations now. And just at the end of this bit of the presentation, before I show you the website, I just want to, again, to use this opportunity to engage you in thinking about our culture, because we have to all contribute to a change in culture. Everywhere I go, the feedback is, I know it from having, you know, worked in this environment myself, is a culture of persecution and blame, which counters sanity around this area. And we all have a role and responsibility to contribute to a change in culture. You know, that we are part of the culture we're in, and we make the culture we're in. We need a revolution of sanity to overturn the persecutory systems we're surrounded by, both internally and externally. We can be our own worst enemy in these situations, actually, our own persecutory responses. So let me just stop sharing and let me share again and show you the website. Here we go. So hopefully you can see that. So you find the web page, you log in, you go to members, supporting you there. And then we have, if a patient dies by suicide, resources to support you. And you'll see we've got a web page there. We've got a booklet you can download. We've got the videos there. And we've got podcasts, personal accounts, and other information. So do use that as well. So I will stop now and I will finish. Thank you.
Thank you, Rachel, for that on such an important and emotive topic, and for sharing your own personal experience. I think it's very brave and really puts a context around what we're talking about today. So we have now finished our presentations for today, and we have still until 5 o'clock, which gives us a good amount of time for our Q&A with our speakers. And as I mentioned at the beginning, the first thing we're going to do to start this section of the webinar is we're going to look at the results of the poll from the start of the webinar. So that's up on your screens now. Questions 1, 2, 3, and 4. So I'm not going to try and speak to that myself, but just give you a moment to look at those. And then I'm going to be inviting the panel to comment on those findings. I don't think we need to take them in. I don't think we need to take them in particular order, Rachel. So please feel free.
I'll come in. Well, because there's two things I want to comment on. The first is about the amount of people who've been affected by suicide, patient suicide. That's absolutely in line with everywhere I speak or talk. It's at least sort of 2/3, 3/4 of the group who've been affected by patient suicide. But what's also interesting is if I ask people to ask, okay, let's just move aside the clinical experience of suicide. Have you had personal effect of suicide? It will tend to be almost the same amount that have had a personal experience of suicide somewhere in their friendship or family group. So this is a big area. The other thing I just wanted to comment on is to do with reflective practice, because this, in a way, is the heart of what will make a cultural change. I mean, it's been absolutely shocking in my career in environments I've been in, very disturbed inpatient wards, where there's absolutely no space to reflect at all. And to have no space to reflect means you're working in a very dangerous environment. If you haven't got space to think, you'll act, or your team will act, patients will act out, and that makes for a dangerous environment to be in. So I would really, really shout out for fighting for reflective practice and reflective spaces where you work. It's your human right to have them.
Thank you, Rachel. I can only echo those sentiments. I wonder if other members of the panel would like to respond to the same issues or other issues in the poll.
I was just going to comment on the first question about people not feeling adequately supported when experiencing work-related stress. And as we kind of talked about in our presentation, that can be a big umbrella term for many, many different things. And I don't really have anything to say specifically other than that it's quite concerning.
And alongside that, so as you say, Sukhmeet, people not feeling sufficiently supported, and quite a lot not getting the opportunity to participate in regular reflective practice. But then we look at the psychiatry support service, and only just over half know about it. So there's something about both having services and offers available, but also how the information is shared and how people can be aware of what there is, and what would facilitate that happening more.
I wonder if I might pick up on that with you, Ros, partly because one of the questions from attendees today was who can access the psychiatry support service? Can an affiliate member of the college access it? I wonder if you could say a bit about that for people who perhaps aren't sure.
Yes, so it is open to college members. We've never turned anyone away. So we would absolutely, if we had an affiliate getting in contact with the service, we would take that call. So we are very much wanting to offer it to people who come to us.
That's fantastic, thank you. Jan, I wondered if there was anything in the poll which prompted you to want to make a comment at all.
I was looking at all the answers actually. I mean, certainly a lot of people not feeling they get support when they have work-related stress is worrying. You know, do people know where to go within their own organisations? There are usually some helps available then, particularly all the hubs starting up to offer psychological therapy following COVID. You'd think that would be a slightly more enlightened picture emerging than feels to be the case there. And I was thinking about the reflective practice, and I wonder if people sometimes make the space for it, feel they're too busy to participate. This question is actually to get the opportunity to participate, so it suggests that it's not there, and it would also suggest that many more people who may have the opportunity are not actually participating. So it's less than 50% that feel have the opportunity to think about their work, actually. And given that we're in psychiatry, which is very much about thinking with people, there's just simply something horribly hollow and missing about that to me. There are different ways of having reflection as well. And you know, this formal reflective practice, also peer review of your cases, thinking about patients with others, that may be helpful to look at too. But yes, it is really worrying, because I think that certainly I do some work with practitioners' health, and the sense of toxicity of build-up of toxins inside. And I think there's a question in the Q&A about that as well. How people digest the toxins, not obviously terrible if you have a serious incident such as suicide and homicide, but actually also just the general pain of the patients that we're working with all the time. How do you actually work that through your system so you can be healthy alongside dealing with that in the front line? So I'm very passionate that people should have access to that.
I think there's something which this discussion is flagging up today about the range of different inputs that are needed, and reminds me of the college diagram at the beginning, showing different aspects of member support that the college offers. And we've also got questions from attendees about, well, what do these things look like, and you know, when are they available? And I'm perhaps paraphrasing, but one of the questions it brings into my mind is people might be wondering, well, at what point could I contact the PSS? Or at what point could I find out what the college offers to support me in the event of a suicide or a homicide? How bad does it need to be? And I wonder if Ros, Sukhmeet, Rachel, you could offer some pointers to those sorts of questions.
Well, it's a very difficult question, isn't it? Because I think doctors are incredibly bad at knowing how vulnerable they are. In a survey we did nationally, you know, doctors said, oh yes, I think in retrospect, I did have a post-traumatic stress disorder, or I had serious depression as a result of this experience of patient suicide, but actually then didn't seek any help, took no time off. So I think in the moment of vulnerability, we're extremely difficult at acknowledging and recognizing it. So I think if you think you need it at all, you probably need it, you know, you probably need it. So really try and access it. There's no shame in asking for help. Nobody's going to tell you that you're not seriously unwell enough. Very, very doubt that's the case. You know, it's important. It's it's a strength to reach out and ask for help. It's not a weakness.
Could I come in on that as well? Because I think there is something about vulnerability and how difficult it is to talk about vulnerability as a doctor. The medical training is about certainty. And as soon as you go into areas of vulnerability, you're talking about uncertainty and unknowing. And I think that's very difficult for people to do. But I think there's also something about reaching out to others that's important when you recognize somebody's had an incident or may not be themselves. So it's part of our responsibility to have that two-way conversation, to reach out to people as well. Sorry, Ross, I cut in front of you there. So.
That's okay. I was just going to add that the psychiatrist support service, how common it is, as you're saying, Rachel, that people don't reach out for help until, you know, quite some way down the line, and our callers will have been struggling with whatever the situation might be for quite a long time before, and it may be that they don't know about the service, and then somehow they stumble across it, or somebody tells them about it, and then they get in contact, and you think it's great we're here for you now, but it's a shame you didn't know about this, or you weren't in a position where you felt you could get in contact, you know, several years ago, and that you've been really trying to cope with this on your own. So the other thing I was just thinking about, and you know, the kind of reflective spaces we have through our PTP, our peer group, and I was just thinking, you know, how differently they get used, and kind of potential we have ourselves to develop the use of those groups in a way to support reflective practice. And I think maybe some peer groups do really kind of function in that way, but perhaps some are more, it's a tick box. We have to just, you know, get your CPD plan signed off, and whether we're missing a trick there in a way.
Thank you, Ros. And I perhaps add to that, just to comment that now that the college has a working group on reflective practice, practices plural, I should say, these are the sorts of questions that I think the college are going to be looking at more keenly in the months and years to come.
I was going to add that I've found with callers that I've spoken to that I'm almost giving them permission to feel distressed, and then actually, because I speak to trainees,
questions appearing in the Q&A now, I think about different aspects of this. What does training and coaching and mentoring look like? What does reflective practice look like? Who should it be provided by? There's a comment from somebody that they really much valued Balint Group as a CT trainee, and it's not available to them anymore now that they've moved beyond that training grade. So there's a whole range of questions there in the group. But I think Sukhmeet might have wanted to come in with a comment. So just to come back to you, Sukhmeet.
I think you cut out for a minute, but I did say something.
Oh, so did I miss your response? I'm sorry, I didn't. I completely missed it. It didn't even come in a broken form.
I wasn't sure if Sukhmeet finished his response. So, are we still speaking, Sukhmeet?
No, it's okay.
Sorry about that. That was a technical issue there. So there's a number of issues which have come up in the Q&A, some of which I think we've covered and some of which we haven't. There's questions about provision for locum psychiatrists, for doctors overseas, for trainees moving into other roles within teams and what's available, questions about coaching and mentoring. So I wonder, I think we've probably got time to try and address some of those now. In no particular order, I was wondering, Jan, whether you would feel able to say something about how people go about getting more trained in coaching or mentoring.
We run various training courses. The West Midlands, for example, we run one training course a year and have done for about 7 or 8 years now, I think. And in the Northwest, Nicola Bayliss is very actively involved in providing training courses, including advanced skills in coaching and mentoring. So these are advertised through the college. We did obviously prioritise people in the West Midlands initially for the first tranche of places for the West Midlands training. But then if the places aren't all taken up, and we've been doing it online recently, the training, then we can invite people from other divisions to join that. So look out for adverts. I'm sure that we can keep a record of those centrally as well through the mentorship email. You can make inquiries centrally through the college to find out when the next training course is. And we run a few special events as well for trainees from time to time. There's certainly training available through the college. There is also training available through HEE that people can get outside of the college if you want to look into that as well.
Thank you, Jan. I am now aware that I've got a little bit of an unstable network internet connection in the last couple of minutes. So apologies, I might have to call on the panel to stand in for their chair if I end up disappearing in the last few minutes. I'm hoping you can all hear and see me at the moment. Ros.
Yes, just kind of following on from Jan talking about the coaching and mentoring, and within the PSS, the Psychiatrist Support Service, we had training from a trained coach to try and for our PSPs to develop those skills, because it's such a useful, they're such useful skills to have, those techniques and feeling confident in using them for us on our calls. And I know there are organisations where appraisers have been trained with those skills as well, and educational supervisors. So if there are opportunities, it's really nice to be able to develop those skills, but we've certainly appreciated them in the PSS.
I wanted to maybe try and bundle up some of the queries where I think there's a bit of a shared theme from attendees about perhaps particular subgroups of college members who might have concerns that they want to make use of services for. So there are comments about people who are involved in trust investigations, working overseas, working in a capacity as a locum or for an agency. I'm wondering whether maybe the theme is, well, are we allowed to, can we, how can the college support us? And I'd like to put that question to the panel.
Well, definitely when it comes to the new peer suicide support group, yeah, if you're traumatized, you want some support, then please approach. You're very welcome. Doesn't matter. You know, there isn't a boundary or barrier in that way. And to reach the support group, you go through the PSS anyway, in any event.
Ros, I don't know if you wanted to add anything to that.
Yes, I was just thinking about, say, if we think about locums, they are potentially a very isolated group if they're not fully part of an organisation. I know we've had some consideration about employers and employing organisations not always being that supportive, but actually to be kind of outside the organisation is probably even more difficult, and kind of so potentially mobile as well. It's not an easy place to be, I think.
Yes, I think that's very apposite. When you said isolated, I did wonder whether that may be what some of those colleagues have in common, is that they feel they're somehow on the periphery, or they're not working in a you might call it a mainstream capacity where they feel they're entitled to access support as much. So I think the encouragement that you and Rachel are offering for people to step forward and make use of what's available, I think that's very important. We're almost at time, and it feels a little bit arbitrary to pick a particular question at this point, but there is one which I think is sort of asking us to think about not just what we give to our patients as colleagues and perhaps what the college is offering in this webinar today, but also about the support that is or should be available through trusts. I don't know whether the college support services that the four of you are representing today are specifically linked with NHS trusts, or whether you have comments about how members might approach their trusts.
Well, I'm happy to chip in about the psychiatry support service. There is something about feeling, sometimes people really want to get the support outside their organisation, I think, because it can just feel too close to home. And so the PSS, by the matching process, we try and match people with a psychiatrist working in a different specialty in a different part of the country and so on. So having that bit of distance, I think, can be for our PSS callers really essential to kind of ensure as much as possible, that guarantee of confidentiality. There's no chance you'll have been working together if you're a different specialty, different part of the country. But I don't know, Rachel or Jan, if you want to say anything more about within the trust, as it were, for support for suicide. And
we'll need to be very brief if we do, because the clock's just gone 5.
I was just thinking that actually it's one of the things about coaching and mentoring is it helps people to think different ways of approaching things. And sometimes that is getting the right person in the trust to sort of go and talk to about, can we do something about this? I think this can be a start. Rachel?
We're writing guidance for all mental health organisations about what hopefully they will be strongly encouraged to put in place within their organisations.
I just mentioned another thing, the Leadership and Management Committee as well, and medical managers, medical directors meet across the college too. So there are forums that these our findings can feed into in general terms, themes get fed up as well. So I think there are some connections made at different levels, which I think are helpful.
Thank you, Jan, and thank you to all our speakers for your varied but linked presentations on these very important topics. And thank you to everyone else who's attended the webinar today and for your contributions. I do hope it's been useful for you, and please look out for the resources from the college team, which were mentioned at the beginning. It's time for us to end, so I'll say goodbye and thank you very much.